actually, it was yesterday, and she was talking about Canada and how she lived there.
Yep.
And when she was there, her dad had cancer for 3 years, and they kept putting it off because the healthcare is free or something like that. And then
Healthcare is not free.
whatever it is, socialism healthcare,
yeah.
she said. I don't know what. And then she was like, so he had cancer for 3 years, and then by the time they decided to actually do something about it, he lost his bladder, his rectum, his everything, his prostate, and I was like, wow, maybe I don't want to live in Canada. I thought about just leaving America.
The Canadian health system, as well as the British health system, are thought to be free.
Like the military.
They are not. It's paid for out of taxes, so the taxes are much higher. The other thing is that I hate to say a quota system because it really isn't a quota system, but for example, if you have to have an artificial hip put in, you may wait 6, 9, 12 months to have that hip replaced. Whereas down here, yeah, it's okay. So with cancer treatment, it's good, but sometimes there are waiting lists. And the waiting lists, we tried to keep them, when I was there, we tried to keep them basically under a month. But in some areas of the country, for example, Ontario, Toronto to be precise, at one point during the 1990s, they had a waiting list of 4 months for cancer treatment. They were actually sending people across to Detroit for treatment. So, however, you will get treatment and world-class treatment at that. But it's sort of, if you can't afford for treatment here, in Canada you would get treatment. Same treatment, but you may have to wait a little while to get it done. Okay, and I've never heard of anybody being kept waiting that length of time.
She said that.
I think she was exaggerating, just sad.
No, she said they wouldn't do like the correct things that needed to be done. They were just like, oh, it's because you're old. You can't pee because you're old. And he was like, I don't think that's it.
Yeah.
Like prolonging the diagnosis, maybe?
Maybe because they didn't want him. I don't know.
It could be anything, and I'm not going to argue with
I do that here
anyone who
too.
says that, but
I don't know. I've never been to
I
Canada.
would be skeptical on that one, having worked in the.
She said it was a very small town. Like
Yeah.
a town of 3,000 people. The closest thing was miles away.
Yeah, that's the other thing about the Canadian health system. You have generalized care. So for example, if you lived in a small town in Alberta where I worked, the main center for treatment in southern Alberta was Calgary. Now, if you had you were 2.5 hours away from Calgary, you had to travel for especially radiation. If you weren't prepared to travel, sorry. Okay, let's get back to the history of radiation therapy. Now, some of these things you'll know, hopefully some of these things you should know. I'm just going to skip over some of these things. So here's a good definition of radiation oncology for those of you who want to have light dinner conversations. Radiation oncology is that discipline of human medicine which deals with generation, conservation, and dissemination of knowledge related to causes, prevention, and treatment of cancer, involving specialized expertise in therapeutic applications of ionizing radiations. In other words, we treat cancer with radiation. Röntgen. Here's Wilhelm Röntgen. Discovered X-rays in 1895. He observed that another type of radiation was produced that could be detected outside the tube. This radiation could penetrate opaque substances, produce fluorescence, blacken a photographic plate, and ionize a gas. He named this new radiation X-rays.
They spelled his name William.
Wilhelm.
I know, they spelled it William.
Yeah, I know, but his name is actually Wilhelm. X-rays because he didn't know what they were. That's why he called them X-rays. This is Frau Röntgen. This is her hand. This is the picture that everybody sees when somebody says, look at the first X-ray. This is Röntgen's wife's hand. He also noted that X-rays could be used to image bones. In fact, one of the first known was his wife's hand. Röntgen characterized and validated his findings in a technical report within 6 weeks. And news of Röntgen's remarkable discovery traveled rapidly around the world. So he was awarded the first Nobel Prize in Physics in 1901, and he discovered them in 1895. So that was a quick turnaround for the Nobel Prize. Usually it's 30 years on that they get these prizes. Becquerel. Why do we know Becquerel? What is Becquerel?
Somebody trying to
One
come
of the
up
classrooms across the way, so ignore them.
I wish they wouldn't do that.
Pardon?
I wish they wouldn't do that.
What?
Makes me really uncomfortable.
What?
When they just walk in behind us.
Somebody walk in?
They tried to.
They open the door.
Oh.
To fucking.
I know.
Unfortunately, there's no lock on this side.
I know. I sit
We
facing
can
the
make
door.
one.
I'll see if I can get one done. Who is Becquerel known for? What's the name Becquerel known for?
The measurement of radioactivity.
Radioactivity, okay. And what did the Becquerel replace?
No, Curie.
Curie. So Henri Becquerel discovered spontaneous radioactivity in a famous example of serendipity and how chance favors the prepared mind. Long been interested in phosphorescence. In early 1896, the wave of excitement following Röntgen's discovery, Becquerel thought that phosphorescent materials such as some uranium salts might emit penetrating X-ray-like radiation when illuminated by bright sunlight. And there we are in 1896, a year after Röntgen. He arrived at the explanation, namely that penetrating radiation came from the uranium itself without the need for excitation by an external energy source. And this is the actual film that came from this. So, Marie Curie, along with her husband, Pierre, showed that Becquerel rays could be measured using ionizing techniques. Radiation intensity is directly proportional to the amount of uranium in the substance. They also isolated and first known elements polonium after Marie Curie's homeland, which is Poland.
So Curie came after Becquerel?
Yes, I think it basically was the same time frame. And radium in 1898. So Becquerel, let me see here, 1896, and radium in 1898, so they were pretty well the same time. They later collaborated with Becquerel and shared the Nobel Prize in Physics in 1903. Obviously, Pierre, Marie, and Pierre. Emile Grube noted a peeling of his hands on exposure to X-rays, convinced his professor and assembled his X-ray machine in Chicago, and the same year learned to treat a woman named Rose Lee with recurrent carcinoma of the breast. By 1960, Grube had instructed over 7,000 doctors in the medical use of X-rays. In the course of his lifetime, he underwent more than 90 surgeries for multiple cancers caused by intense, ongoing exposure to radiation. Because they kept sticking their hand inside to say, oh yeah, look. Yeah, you can see it. Yeah. Radiation was generally held the biggest dose tolerated, and given as fast as possible was the best treatment. Of course, we know this is stupid now, but then they had no measurements. They'd irradiate the body till it got red, and that was it. During the period roughly 1920 to 1930, Claude Rigaud argued that a differential effect of X-rays on cancer and normal tissues would be the best, obtaining by giving the treatment slowly. For example, healing was much better when skin cancer was treated over a period of a week rather than a day. Poor sheep. He exposed sheep testicles to large doses of ionizing radiation. The rams could be sterilized with one large dose, but the quantity of radiation also caused skin adjacent to the ram's scrotum to have skin reaction. It's found that the original dose was fractionated or broken into smaller doses. Over a period of time, the animals would become sterile, but with considerably less damage to the skin. Hence, fractionation. And this is the basis of why we use fractionation. One of the most underlying principles of radiation therapy, and we always use it. Henry Pitard pioneered the use of fractionated radiotherapy in a wide variety of tumors. Reportedly impressive results using the approach with locally advanced laryngeal cancers in 1934. Okay, so this, I believe, is available. Okay. An important limitation was the early X-ray machines, their inability to produce high energy, heat penetrating beams. It was thus difficult to treat deep-seated tumors without excessive skin reactions. Many early advocates therefore thought about using radiotherapy. This modality dates back to Pierre Curie, suggested to Danlos that a radioactive source could be inserted in the tumor. It was found that the radiation caused the tumor to shrink. In the early 20th century, techniques for the application of radiotherapy were pioneered by the Curie Institute in Paris. Ralston Patterson was a radiologist who had a keen interest in new advances related to the field and was appointed as director of the Hope Freedom Institute in 1931. That was in Manchester. Christie Holt, which is the hospital, is still there actually. He went to build a world recognized center for the treatment of cancer by radiation. Among the team was his wife, Edith Patterson, who started research work at Christie Hospital and who became a world-renowned pioneer in biologic dosimetry, childhood cancers, and anti-cancer drug treatment methods. So the Christie Holt Hospital is still there, it's still functioning, it is still world-renowned. Herbert Parker. Everybody remembers when I was talking about Parker Patterson? Nobody remembers me talking about Parker Patterson rules. Okay, we'll get to them in a little bit. Parker was a medical physicist at the Holt Radium Institute who developed the Manchester system for radium therapy along with Patterson. The techniques enabled physicists or physicians to arrange radium needles or tubes in the configurations that would maximize radiation dose to tumor while minimizing the healthy tissue. The Manchester system for therapy was the most comprehensive and widely used system in the field of radiation therapy that's still being used today. Following initial interest in radiotherapy in Europe and the US, and its use declined in the middle of the 20th century due to problems of radiation exposure to operators. However, the development of remote after-loading systems, which allow the radiation to be delivered from a shielded safe in the 1950s and 60s, reduced the risk of unnecessary radiation exposure to the operator and the patients. Does this look familiar to anybody? HDR, yeah, this is where it all came from. This together with most recent advances in 3D imaging modalities, computerized treatment planning systems, and delivery of equipment has made radiotherapy a safe and effective treatment for many types of cancer. Okay. Here's somebody I actually have met. Harold Johns, Canadian medical physicist, sent a request to the NRC asking them to produce cobalt-60 isotopes for use in a cobalt therapy unit prototype. On the 27th of October 1951, the world's first cancer treatment with cobalt-60 radiation took place at the Victoria Hospital for a 43-year-old cervical cancer patient. This marked an important milestone for the fight against cancer. So, you can't see it very well, but this is one of the original isocentric cobalt machines. Anybody get any idea what this might be? This is the cobalt machine head. This is the treatment head. What do you think this is? Anybody get any ideas? Guess? Okay, so this is the treatment head. What are the treatment heads covered in? This
Lead?
particular one, it was, well, yeah, lead is around the source. And the coverings, which are now fiberglass, were actually steel. But yeah, it's lead. This whole thing is lead. So what do you think this might be? If you're tipping something with lead on it, what might that be?
Counterweight.
Counterweight. That's exactly what it was, partly. Partly it was a counterweight, partly it was what they called a beam stopper. The rooms at that point weren't that big. So the beam stopper was exactly opposite where the head of the machine is. So it would stop the beam, and therefore you could use a smaller room. So despite advances made in radiation therapy technology, the cobalt unit remains the world's main radiotherapy machine. due to its cost effectiveness, reliability, and ease of use. It is prevalent in developing countries. The technology is currently used to treat roughly 70% of the world's cancer cases treated by radiation. Not, of course, in the US, because it was not very well received in the US. An exciting development was the introduction of high-energy micro-multi-splinter accelerators. Such machines were capable of producing high-energy, deep-penetrating beams, allowing for the very first time treatment of tumors deep inside the body without excessive damage to the overlying skin and other normal tissues. This machine was an isocentric or non-isocentric, can you tell? Just by looking at the photograph.
Non-isocentric.
Non-isocentric, why do you say that?
Well, because I don't see a bed and something you can rotate around to get an isocenter.
Yeah. It was a non-isocentric machine, that's correct. It was what they call a stand-mounted machine. So Kaplan and Gerzon developed the first medical linear accelerator at Stanford in 1956. First patient to be treated using this machine was a 2-year-old child with a retinoblastoma. Treatment highly successful for more than 40 years later. This patient remains free of disease with good vision. This shows you. The advent of computers, newer technology, the radiation therapy treatment planning systems underwent a drastic makeover. 1990s, the 3D conformal, a form of radiation therapy where the fields used are designed such that the radiation goes and mostly delivered to the tumor while the surrounding tissues receive little or no radiation. So this is the treatment planning system. You would see this. So these are the fields that you would see on the computer screen. This is a medial and a lateral breast. And you'd see that this is the sternum. And you can see the rest of the body here. Tends to deliver tumoricidal dose to the tumor while minimizing the damage to the surrounding tissue. 3D information about the patient's body is supplied by the CT sim. IMRT, intensity modulated radiation therapy, is an advanced form of 3-dimensional conformal radiotherapy. It uses sophisticated software and hardware to vary the shape and intensity of the radiation delivered to the different parts of the treatment area. So image-guided radiation therapy, while not truly new, is rapidly growing in popularity, primarily due to the widespread adoption of new linear accelerators, which function both as treatment and imaging machines. This is exact tracking. So what they're doing is they're imaging the tumor, and these images are calculated, and if the tumor moves out of a certain area, the therapist on the machine will know about it.
So the exact track is not tracking surface anatomy, it's actually tracking the internal?
Yes,
Okay.
Yeah.
Ours is different than that.
it's not vision. Vision is surface.
The exact track. It's like something, she said it was like the same thing as like a cone beam. remember.
So thus we have seen in a period of just over 120 years, the modality of radiation therapy has evolved rapidly with some anonymous rays to present a scenario, or present scenario, where radiotherapy is almost indispensable when it comes to cure of cancer. Growth means change, and change involves risk, stepping from known to the unknown. Okay. What percentage of patients, of cancer patients are treated with radiation? Anybody know? 60? Any advance in 60?
I think more.
Or anything different than 60?
I think more.
85.
It's around 75. So 3/4 of all cancer patients are treated at some point with radiation. Whether it's before chemo, after chemo, before surgery, after surgery, alone, in combination with chemo, at some point, all of those are treated. Okay. Questions on that? That's pretty easy because we know all about that. Right? We should have known all about that. No, I don't know. Okay. So, radiation therapy. We need to know beam energies and field sizes. What kind of beam energies do we use? Normal linear accelerator. Yeah, megavoltage. What kind of energies might be on or in use by a modern linear accelerator? What's the minimum energy in a modern linear accelerator? Is it 4? 6. You don't get a linear accelerator these days that is less than 6. There were Linacs who did 4.
We do still have one. The first one I was on, they have 4.
It's old.
4 and 6. Yeah.
Yeah.
That's why, 'cause I took a picture of that. We have
Yeah.
it printed in our, or we had it printed.
It's very unusual still to have a Linac working that has 4 MV. That's photons, right?
Yes.
Okay. So what are the other energies that you can have? Normally they're what is called joule energy. What does joule energy mean? What is joule energy? If I said to you that a Linac was joule energy, what does that mean?
It could be 2 different energies.
2 different energies of photons, electrons, what? If the joule energy machines, we're talking photons. We'll get to electrons in a minute. So normally they would be 6 and whatever. So what energies did we have in the sites that we were at?
I think that was 18.
So 6 and 18, 6 and
10 and 6 at the for chirping.
Since I didn't hear the one about True Beam.
6 and 10, and then FFF are both on variant true.
Okay. So 6 and 10, 6 and 18. What about you guys?
I feel like ours was 15, but let me check.
Sorry?
I feel like ours was 15 for some reason.
15? Okay.
Elective synergistic, I think, was 6, 10, and 15.
Yeah, 15, 6 and 15.
Yeah, okay. What about anybody else's? What is it in, MD Anderson?
A lot of 6 and 10.
Pardon?
6 and 10.
6 and 10, okay. So 6 and 10, 6 and 18, 6 and 15. That's really pretty common. So what about electrons? What were the beams in electrons?
6, 9, 12, 16, 20 mega electron volts.
6, 9, 12,
16 and 20.
15 and 20?
16 and 20.
16 and 12, okay. Anybody get any other ones? 6, 9, 12. Some departments have 15, some departments have 16, 20. Some go as high as 23. Anybody get any other energy, electron energies? No? Okay. So, now we have the energies. Who decides what the field sizes are? Who in the department decides what field sizes we use?
The dosimetrist?
Pardon?
The dosimetrist?
The dosimetrist, in conjunction sometimes with the doctor. But normally, depending on the relationship between the doctors and the dosimetrist, they usually leave it up to the dosimetrist, because remember, the majority of departments these days are using IMRT. And there's no real set field size for IMRT, is there? What do you set when you set IMRT? Do you set a field size? Do you? No? You can actually say no if you want.
We're scared.
No, they don't. They usually don't. Sometimes what they'll do is they'll set a 10 by 10 to get a beam, a light beam, so that you can actually position your patient. But for actual treatment, no, there's usually no field size. What's the largest field size for a normal Lanai?
40 by 40.
40 by 40, okay. What's the minimum?
5 by 5 or?
What's the minimum that you would normally use? 5 by 5?
5 by 5.
Usually. What's the minimum that you can get your jaws to, if you're setting the collimator, setting the field size manually? I know that most people will do it automatically, but if you sit there with the pendant or the hand control and set the field size manually, how low can you go? You ever tried that?
I would guess as small as the leaves are.
But you're not using the leaves. The MLC leaves are out of the way. You're using the jaws. There's a difference, right? The jaws are the ones that set the field size. The MLC are what sets the shape. So how low can your jaws go? You can actually close them all the way down. You can go to 0. Sometimes they'll stop at 1, but you can actually close the jaws all the way. And some departments, actually, that's part of the nightly shutdown. is that they close the jaws all the way. Has anybody actually been there when they close the machines down for the evening? Okay, one. Anybody else? Anybody seen them? So what, just while we're here, what is the technique that they use to close the machine down?
Well, for
When
ours,
you're
he
going
would,
home for the day.
he would set them at the gantry down to 60, so it was kind of, leaning down, and then he would rotate the collimators to 90, so they wouldn't weigh on each other, so they wouldn't slide.
Mhm.
That was all we did.
Mhm. Okay, you didn't shut the jaws down.
He didn't shut the jaws.
No, that's fine, that's fine. And the idea that they turn the collimator to 90 is because the jaws go that way. So they want to do that. And the reason why they'll actually turn the gantry to a certain angle, it's usually 90 or 270 depending on the type of machine you have. Did anybody tell you why?
In case the machine gets wet.
Pardon?
They told me in case the machine gets wet for any reason, like flooding, rain.
No.
That's what I was told
That's
too.
what I was told, like, cause.
That it would drip
water
on
would
the
run out.
Equipment that would go out.
The actual reason why is, you know that you have a water pump, right? And the water pump is in one particular area. So if you turn the gantry around so that the water pump that leaks goes right onto the floor. If you turn the gantry the other way and the water pump leaks, it goes right through the electronics. That's the reason why. So you turn your gantry so that your water pump, if it leaks, goes onto the floor, makes an awful mess, but whatever. But it doesn't go through the electronics.
He would also raise the bed to like 218 or something he said also for water. I don't know what that was.
It could be that they've had damage done to the bed because of the water pump. But that's the reason why they turn the gantry. Okay, so let's go ahead here. Okay, beam energy. So we all know that superficial, orthovoltage, and megavoltage. What is so superficial is anything from 80 to, I would probably say 100 for superficial. And orthovoltage, you can go up to about 400,000 or 500,000. So 100 kV to about 500 kV. And megavoltage is any energy greater than what? Huh? 1 MeV. 1 MV. Everybody know the difference between MV and MeV? What's the difference?
One's an
Which is which?
energy.
MEV is what?
Yeah, so if you, and brachytherapy is also MEV. So if you're saying something that deals with a linear accelerator and photons, then it's MV. If you're using electrons or brachytherapy, it would be MEV. Don't get them mixed up, because you'll be marked wrong if you use the wrong one. Okay, so field size range. So we can do large fields for total body, standard fields, and irregular fields, use of MLC, and small circular fields. Sometimes we use MLC to do radiosurgery. Sometimes it's actual collimators that you actually put in place. So that would be radiosurgery. This would be normal treatment with MLC. and then you'd have large fields. Whoop. So SSD and SAD. SSD technique is, what's different? What's the difference between SAD technique and SSD technique? Well, this is something you guys should know. Tell me the difference between SSD and SAD.
SSD is the source to the skin. And the SAG is the source to the tumor, right?
Yeah.
To the what?
Which one is isocentric?
SAD.
Yes.
Yes.
Because it says it on the screen, right?
Yeah. I read it and said no.
Yeah. So SAD is what we use normally, right? That's what is usually used in most of the treatments that you're using. Give me an example of an SSD technique.
Electrons.
Say again?
You got it, Christina.
Electron.
Electrons, yeah, electrons. What else? An SSD technique.
Oh, like a skin cancer.
Hmm?
Like a skin cancer. Something that's like surface.
Skin cancer would be treated with what?
I mean, you can do electrons or photons.
Yeah. Or photons, yeah. Single field spines sometimes are done with an SSD technique. Total body is done with an SSD technique, albeit very much extended, but it's still an SSD technique. So here, distance from the source to the surface of the patient is called kept constant for all beams. So you're treating here, the distance from the source to the skin, this is SSD, remember, is 100 with most types of treatment. Is 100. Lateral or the oblique is also 100. Both obliques are 100. What's the problem with doing that? So you set the patient up with their tattoos and the lasers. You drop the bed, drop the patient. So that it measures 100 on the skin. Everybody good with that? Right? So if you want to do an oblique, what do you do? Talk me through what you do.
I'm guessing you have to shift the patient to acquire the SSD
How?
100.
How?
Don't you rotate the gantry?
How? Which way? Up, down, sideways, what?
Probably farther away, so the opposite direction that the gantry is coming from.
Hmm. So, you have this set at 100. You rotate the gantry to, in this case, it's about maybe 80 degrees, or actually, sorry, about 100 degrees, right? Now, if you set to 90, all you would do would be move lateral. Move the bed away from the machine. However, we have obliques. What do we do now?
You're gonna go lateral and anterior, or like up, superior.
So it's important that you know exactly where you want to treat. You must have marks on there, right? Otherwise, where are you treating? right? If you didn't have marks on, would you be able to move the bed to match? No. So you have to have marks on there. And then the same on the other side, you do exactly the same. You move it up, or out, or down, or out, or both at the same time, because you're doing obliques. However, with an SAD technique, your distance to the isocenter or point of interest is 100, right? 100 to the tissue, 100 to the tumor, 100 to the isocenter, call it what you will. So you're doing obliques, what do you do then? You swing the gantry around, you have to move it. You have to move the patient.
The tumor is isocentric, should be exactly where it's supposed to be.
If you have to move the bed, you've done something wrong. So how do we know what the SSD is to each of these points? One here, one here, one here. Are they going to be the same? The skin SSDs, are they going to be the same as each other? Yes, no, maybe, kind of, don't know, could care less. How do you tell what the SSD is?
I guess they're 100 minus whatever the difference is from the tumor to the,
So how, yeah, but how do you tell what the SSD is? There's a mechanism to measure.
Turn on the button, or on our machine.
Which button?
The SSD
What are you looking for? What is it called?
It's not called SSD on ours. Do you remember what the button's called, Mallory?
ODI maybe?
Ours is labeled SSD.
Yeah,
Ours is distance, I think.
Yeah.
yeah,
It just says distance.
distance,
Yeah.
SSD, ODI, whatever it is. You hit that button or press a button on the, whatever it happens to be, and there it is. You can read it, and you record it once a week, at least. Whether it's done or not, that's how it's supposed to be done. Okay,
Not once a week, once every 5 fractions.
good.
Yes, girl, get her.
Good morning.
I knew it would get in there somewhere. Yes. Good. Okay. So, in contrast to the SSD technique, the SAD technique requires no adjustment to the patient setup when turning the gantry to the next field, or it should not. If it does, you have a problem. Process of determining the volume of malignant disease consists of several distinct steps. Varying concentration of malignant cells, probable changes in the spatial relationship between volume and beam during therapy, movement of the patient, and possible inaccuracies in the treatment setup. So, movement of the patient, we know, right? Possible inaccuracies in treatment setup. We know that there are somewhat inaccuracies, maybe only millimeters, but that's inaccuracies. Probable changes in spatial relationship between volume and beam during therapy. What the heck does that mean? Take the prostate.
Movement of the tissue.
Movement of the tissue. We know that the prostate moves quite a bit, as a matter of fact. So that could be, and tumors are not always right. They're very rarely right. And that's why when you're doing the IMRT, you'll see the MLCs move all the time. That's so that they can actually compensate for the shape of the tumor. So, volume definition. GTV is the gross, palpable, or visible, demonstrable extent and location of malignant growth. In other words, it's the tumor. Gross, palpable, or visible, demonstrable extent and location of malignant growth.
I feel like they made that word up.
Demonstrable? No, it's a word.
Heard of that.
It's a word. So the GTV is usually based on information obtained from a combination of imaging modalities, CT, MRI, ultrasound, etc. Diagnostic modalities, pathology and histology reports, and clinical exam. So the GTV consists of the tumor that is visible or is demonstrable. So you can see it on the CT, you can see it on the MRI, etc., etc., etc. The CTV is a tissue volume that contains demonstrable, in other words, GTV, and/or subclinical microscopic malignant disease which has to be eliminated. So you have the GTV, which is smaller, and then the CTV, which basically takes into account the microscopic malignant disease which we think or we know is there. This volume has to be treated adequately in order to achieve the aim of therapy, cure, or palliation. What comes next? You get GTV, CTV. What's the next one?
PTV.
PTV, okay? So the CTV often includes directly surrounding the GTV, the main glycogen. Example, positive lymph nodes. CTV is an anatomically clinical volume, usually determined by the radiation oncologist, often after relevant specialists such as pathologists or radiologists have been consulted. And then you have the ITV, which we don't usually use very often, so let's put that last there. There we go. So the planning treatment volume is a geometric concept. It is defined to select appropriate beam arrangements taking into consideration the net effects of all possible geometric variations in order to ensure that prescribed dose is actually absorbed in the CTV. PTV includes internal target margin and an additional margin for setup uncertainties, machine tolerances, and intra-treatment variation. So it's usually a centimeter or so around the CTV. Is it always a centimeter?
Could be more.
Very rarely is it more. Could be much less. So your PTV is basically your margin for error. Patient breathing, patient movement, organ movement, inaccuracies in setup. That's what the PTV is for. For a normal type breast, which is a 3D breast, or a normal type lung, which is a 3D lung, centimeter is probably good. For IMRT, it would be much less than a centimeter. It would be 2 or 3 millimeters, perhaps. For stereotactic, you have no margin for error. And that's why you need the extensive patient immobilization when you're doing IMRT, if you're doing stereotactic. So organs at risk. An organ whose sensitivity to radiation is such that the dose received from a treatment plan may be significant compared to its tolerance, possibly requiring a change in the beam arrangement or change in the dose. So you should have within interlocutal, your OARs are outside of the treatment volume, but sometimes you can't help it, they have to be inside the treatment volume. So specific attention should be paid to organs that, although not immediately adjacent to the CTV, have a very low tolerance dose, such as the lens of the eye. And if you're treating the brain, you must not treat the eye. If you're treating the nasopharynx, who here has treated nasopharynx? How high does the nasopharynx field go?
I thought it went up behind the deeper than the orbital cavities.
It does, but you still get some scatter there. So the nasopharynx basically comes up to about here. It should be around the EAM. So you see how close that is to the eye. So you have to be extremely careful about the lens. The lens is the most sensitive part of the eye. And then of course you have the spinal cord. You have to be careful whatever you're treating. If it's close to or adjacent to the cord, you have to be extremely careful. We're not worried about the spine per se, we're worried about the cord. Okay, so complete prescription of radiation treatment must include the definition of the aim of therapy, volumes to be considered, and prescription of dose and fractionation. So the aim of the therapy, what might that be? There are usually two aims.
Curative and palliative.
Pardon?
Curative and palliative.
Curative and palliative, that is correct. So volumes to be considered. So we're looking for the volume for whatever it happens to be. And prescription of dose and fractionation. What dose are you going to give them? Total dose, over how long, and how much per day. So you're giving 4,500 in 4.5 weeks. 200 a day. without 4,600. So when the dose is given, when the dose to a given volume is prescribed, corresponding delivered dose should be as homogeneous as possible. Due to technical reasons, some heterogeneity has to be accepted. So, the rest, right? So we're treating here. And remember, we have some clearance of the breast. The dotted line here is the PTV. So what's the breast made up of normally? What's the breast made up of, guys? Adipose tissue and glandular tissue. So we have adipose and glandular tissue, which is basically soft tissue. What's this down here? Chest wall. No. This. Lung. Thank you. Lung. Chest wall is here. This is the breast, this is the chest wall, this is the lung. You notice that we're giving, 85% to the lung. But it's only about 2 centimeter strip lung, which is normal. Why do we need that strip of lung?
Just to make sure you're getting it all.
Yeah, so the breast tissue sits right on top of the chest wall. The lung is right underneath. So in order to get in order to make sure that you get all of the lung, or excuse me, all of the breast, you have to take a little bit of lung. And that is explained to all the patients. And there may be what they call lung fibrosis, but that's kept to a minimum. And we have to make sure that that is under control, and we keep that advised, and we make sure that we keep an eye on, or the physicians make sure they keep an eye on that. Okay, let's stop here and take 15 minutes. 15 minutes, guys. Christina,
Can I see you for 2 minutes, please?
okay, back here, will be 20 past.
Well, by that, by that clock up there, it's 15 minutes.
Because
I'm going to find some caffeine now. I can't feel great today.
I have to chew my mouth open, so I'm really sorry for the gross noises that are about to
Poor
occur.
thing.
How are you
Be
feeling?
swollen.
It was supposed to end tomorrow, or yesterday.
How many days have been? It's usually like 5 to 7 days, I thought. How
I got it on Friday early morning, and he said, yeah, you should be good by Sunday. You can go back to the gym on Monday.
2 days?
Yep.
3 days?
You
Lie. I don't know why he would lie like that. I remember having mine done, and it was like a good solid week, and that was if I behaved myself and ate things that I was supposed to eat and not pushed it. But if you eat things and get your tissues all irritated, it goes on for like a lot longer. It's miserable. use special mount rinse,
Special what?
rinse to swish with.
Oh, yeah, it's so good.
I know.
What exactly did you get done?
I have 2 bone grafts put in because I'm missing the teeth right in front of my canine. And I didn't have enough bone for them to just screw them anywhere. So they had to put in pig bone to make sure that my bone will attach to it so that they can actually screw in anywhere.
Oh, wow. Very expensive.
Yeah, it hurts. There was a weight for it.
Oh, goodness. They didn't put you under for that?
No, he said, we don't do that here. And I said, okay.
Okay, I think it'll be fine.
Yeah.
Did they at least numb it very well?
He started out, my body metabolizes stuff really quickly. So in the middle of it, I was like, I can feel that. He's like, oh, really? And I was like, yeah. And he's like, okay, let me stop.
I'll give you some more.
Yeah, he like overdid it after that, and I was like, whatever. I'd rather be overnumb than under.
Yeah, there you go. Well, at least it'll be worth it at the end.
Yeah, I'll pretty smart over it. I know. I was looking at, actually,
You guys got goodies?
yeah, maybe you should follow us for once in a while instead of
Yeah,
just sitting
maybe a little
here.
permit.
Oh, nobody
Yeah, you
stopped
did
the
that
recording. Hope you guys weren't talking.
Sending you emails about where you're going as of next week,
Oh, yeah.
okay? And I will be sending emails to the sites. So with some of the sites, you can expect phone calls, with others, just arrive.
That Flagler, you just arrived.
Pardon?
So that Flagler, you just arrived. Whoever gets Flagler.
Yeah.
I don't answer phone calls. Got phone calls. I didn't, and you can tell you're not going to.
I'm not gonna get anything. I'm just
And you
gonna
have
show.
to fill out a form. For like HIPAA and stuff like that.
Yeah.
But you don't get phone calls. You'll get an email. I think we got.
Gainesville, we got an email.
I just parked right in front of
So what are they giving out downstairs?
a flash drive, a mask, and a phone holder.
And,
What?
Phone holder?
A phone holder?
yeah,
It's
perfect.
perfect,
class.
right?
Yeah, okay.
And,
I don't know how to
hand
use
sanitizer.
it.
Oh, you, what? Oh, hand sanitizer.
Yeah.
Like this?
Other way.
One fluid out.
Of
Ah,
course you do.
Sorry,
It's okay.
I did run.
Uh-huh.
Please. Never mind. I forget it.
What?
Nothing.
say it.
No.
Come on, you
No,
always
no,
do
no, no,
this.
no, no, no.
This
You
is
said
like 2
15
times
minutes.
now.
Seriously, I get so
you
excited.
said
What?
you said 15 minutes at 10:15 and said see you at 20 after, which is 5.
Yeah,
Which is 5 minutes.
because everybody wasn't back at 20 after.
Yeah, but I was saying you said a 15-minute break, but it was only 10:15.
She was saying, according to that clock up there, it was,
Oh, okay,
it was
okay.
10:05 at that point.
Okay, because I was like, it's 10:15.
Okay.
20
So-
after is only 5 minutes.
That's why she.
I know. I know that's why she hates me. All right, I'm done. Sorry.
No, you're not.
Okay, those reference point is
That's why I'm
located
going
a
on
point
now.
chosen to represent the delivered dose using the following criteria. The dose reference point is usually the isocenter for most isocentric techniques. The point should be located in a region where the dose can be calculated accurately, i.e. no buildup or steep gradients. So where might a steep gradient be in the body? Where might a steep gradient be? There are two areas that I can tell you right off. One is a breast, which is a steep, kind of a steep gradient. The other one is the larynx, or the throat. It could be that we're treating the ribs. So if we're doing ribs this way, then you have a steep gradient this way, right? So the point should be located in the region. The point should be in the central part of the PTB. So if you have a PTB, the reference point should be in the middle of the PTB. Makes sense, right? And for multiple fields, the isocenter is recommended as the ICRU reference point. So the isocenter is always, for multiple fields, which is what we usually deal with, is the reference point.
Does it say what ICRU stands for?
Yes?
Where is it? So you know. There it is.
No. It's the International Council on, I'll look it up, I'll let you know. So for a three field, excuse me. So for a three field, the reference point is right here. So this is the isocenter, therefore this is the reference point. Make sense? Okay. So for single fields, so you're doing a spine, single field spine. The point on the central axis at the center of the target volume. So if you do you're doing a single field spine. And this is, oops, sorry, this is the central axis. There's your central axis. Where's your reference point? From 0. In the middle. Right here. Parallel opposed, equally weighted fields. What does equally weighted mean?
Same dose on both sides.
Same dose on both sides.
It's like 50.
Okay. What do you mean by same dose on both sides?
Like if you're gonna get 50% on this side, you're also gonna get 50% on this
Okay.
side.
So for equally weighted fields, the point on the central axis midway between the beam entrance point. So you've got a field coming in here, a field coming in here. Your separation, which is what? What's the separation? Define separation.
I wasn't sure what that was either, but is it from where the beam enters to where the beam exits, the distance between the two areas?
Yeah. It's an easier way to say it. Thickness of your patient. Either APPA or laterals. You have an APPA separation, a lateral separation. We went up over this several times when we were doing upstairs. You should know this, guys. Okay, so the point on the central axis midway between the beam entrance points. For parallel opposed, unequally weighted beams is the point on the central axis at the center of the target volume. And for other combinations of intersecting beams, which means 3 fields, 6 fields, whatever it happens to be, the point at the intersection of the central axes insofar as there's no gradient at this point. So if we had 3, 4, 6 fields, they would all intersect at one point, which is usually the eye as a center. So that's the reference point. So data acquisition simulation. Simulation process of an entire treatment using computerized treatment planning system. The patient anatomy and tumor targets can be represented as three-dimensional models. So this is what you see on the planning screen, or on the dosimetry screen. So the CTV is violet. So this is the CTV. OER, both lungs are yellow, and the spinal cord, which is green. So this you can see in the treatment area, in the treatment planning area. So your reference point would be somewhere in that CTV area. So why do we put both lungs? Obviously, we're not going to treat that size of field, right? We're only going to treat a little bit of the field. So, but I guess this particular physician wanted all of the lungs shown. But as you go through, this is a CT slice up here. So as you go through the slices, here's one, here's one, here's one. So as you go through the slices, you will see lung, you will see spinal cord, all the way through, right? Because you're going through each slice as you go. So the type of gathered data varies greatly depending on the type of treatment plan generated. So a manual calculation of parallel opposed beams is relatively easy. Requires less effort. A complex 3D plan with image fusion or an IMRT plan with image fusion would be much more labor intensive. And anything with MLC would require some work. So patient dimensions are always required for treatment type or monitoring unit calculations, whether read with a caliper from CT slices or by other means. So what do you use? How do you get the patient's dimensions normally? You're doing a CT plan. Where do the patient dimensions come from? How thick the patient is, how big the patient is. Where do they come from? What does the dosimetrist have in order to do the plan? What do they need?
CT scans?
CT scan. What does that give you? What does a CT scan give you?
Well, you can measure it.
Hmm?
There's like a little button that you can like measure.
Yeah. But the CT scan will give you, as I said, it will give you the dimensions of the patient, as long as you can get all the patient into the scan. If they're really big, then you may have a problem. But that's where the dimensions come in. you can get all of that from the CT. What if you don't have a CT? How do you get the patient's contour? How do you get the patient's separation, if not from CT?
Physical contouring.
Physical contouring, with what? A what?
A coat hanger. At least that's what they described it as, like a piece of metal that was bendable that could go around the patient's contour. They shaped it to the patient's
Yes,
body.
it's usually a piece of solder wire. Don't put that in your exam. Because one, you'll be marked wrong, and two, they'll die laughing. If I had that answer in an exam I was marking, I would be wrong. Because that may be the name that's called in your department, but that,
They didn't call it a coat hanger, they just said it looked like a coat hanger because it was bendable and about the thickness of a coat hanger. They called it something else.
okay, yeah. So it's usually something like solder wire. Everybody's seen solder wire, right? No?
You said solder?
Yeah,
Solder wire?
yeah, same thing. Everybody's seen that? Everybody's had solder wire?
I've
No?
seen it in images, like, but I haven't seen them actually do it.
No, but I'm talking about not
In
as far
general.
as radiation is concerned, but has anybody not seen in real life a piece of solder wire? I don't believe that some people have never seen solder wire.
If you have a
No?
dad, you probably should have seen it.
Pardon?
I said if you have a dad, you probably should have seen it.
Yeah. Okay, so it looks like
I saw it without one, too.
it's wire. It's kind of thick wire, and you put it around your patient,
Very soft.
very soft. That's why you can,
Hold it.
so you mold it around your patient, then what do you do with it? You mold it around your patient. Do the ladies at, in Gainesville tell you what they use, how they,
They didn't tell me anything, it was Dosimetry that told us.
Okay,
Because it was on the
so did
line.
he say how it was used?
He said something about once you took it, the contour of the patient, they could lay it out on this paper that you could mark the measurements on it.
Mm-hmm.
There was also this lighted board, I forget what that was called.
Yeah.
That they could make
Yeah.
films of it.
So basically what it was a piece of wire that you put around your patient. You marked various spots, usually the lateral borders and the center. And then you extremely carefully take it off your patient, put it on a piece of paper, and you draw around it. Being extremely careful not to move it, because you need 3 fingers, actually, you need 3 hands to hold it and draw around it. And it's usually on graph paper. Everybody knows what I mean by graph paper, right? Good, okay. So it's usually done on graph paper. And that can be digitized into the planning computer. What about separation? Now, if you're doing a contour, that might give you a lateral separation. What about an APPA separation? How do you find that out? We did this last semester.
Calipers,
Calipers, yeah. So what is the APPA separation? It's the distance between the front and the back, or the side to side one, that's a lateral separation. APPA is front to back. You take the calipers, you put one thing here, slide it down, you get your separation in centimeters. Same with the lateral. If you're doing, as I say, if you're doing the contour with the wire, then you have the lateral separation as long as it was past the lateral. So what other thing can we use to do a contour if you don't have wire? Anybody heard of plaster of Paris? What is plaster of Paris?
It's like a substance to make molds.
Plaster, and then it hardens as it dries.
Yeah. So what does it, how does it come? Is it powder? Is it?
It's really powder.
It's usually powder, huh? It's the stuff that they used to make casts out of for broken ankles and broken legs. What the heck is it? Oh, okay.
It's like a half full hand sanitizer thing.
Yeah, okay. So it actually comes in bandages. You can get rolls of what they call plaster of Paris bandages. And you take off a strip of bandage, whatever it happens to be, and you dunk it in water, and then you put it over the patient's area, and you can actually be used to make masks out of them. But for contour, what you did was get a long strip, maybe this wide, this long, and you folded it so that you had a nice little strip of bandage. You dumped it in water, take the excess water off, and put it around the patient. And leave it till it dried, and you had a nice contour. Same thing, put it on a piece of paper and draw around it. Yeah, it's kind of messy, but it works. Okay, type of dose evaluation also dictates the amount of patient data required. DVHs require more patient information than point dose calculations of organ dose. So you can look to see how much dose that you would get in the organ, or you can have DVHs, which is what? What is a DVH? You'll learn more about this semester. Can anyone tell me what DVH stands for?
Is that the half value or something? No?
No, it's called a dose volume histogram. DVH, remember that. That's gonna come up. If you have access to the plans in the department, then
I've
you
seen
can-
them before, I just did not. know
Yeah.
before.
so you can ask to see those volume histogram. They should be accompanying the actual plan, but we'll go over what they look like and what they mean later on in the couple of weeks. Okay. Patient information required for treatment planning varies from rudimentary to very complex data acquisition. So distances read in the skin, manual determination of contours, acquisition of CT information over a large volume, and image fusion using various imaging modalities. Fusion, image fusion. What's that? Image fusion.
When you superimpose.
Hmm?
When you superimpose
What?
images.
Hmm?
Images. Different images.
Different images, okay. So we're talking DRRs and portal images?
Sure.
Example,
Not really.
No.
It's not what we would count image fusion. That's not what we count image fusion.
Like CT and MRI.
CT and MRI. So you have a CT that the patient, we've just done a CT image on, or CT slices on. And you've called for the MRI image, we'll see a brain. So you have the MRI images and the CT images, and you superimpose them. So you get the anatomical features from both the CT and the MRI. And again, patient information required for treatment planning in particular depends on the symptoms. So that's, okay. So 2D planning. Single patient contour. Acquired using lead wire or plaster strips and transcribed onto a sheet of graph paper with reference points identified. Simulation radiographs are taken for comparison with port films during treatment. So this is old school. For irregular field calculations, points of interest can be identified on the simulation radiograph, and SSDs and depth of interest can be determined at simulation. Organs at risk can be identified and their depth determined on the simulator radiographs. We have CTs, so we don't need the contour normally, because we can get it from CT, right? The radiographs come from CT. They are called, what are the radiographs called that the dosimetrist makes from CT? DRRs. So you have the DRRs, which replace the simulation radiographs. And the DRRs are taken in comparison with the portal images. The DRRs are usually electronic, but they can be printed out for those physicians that are electronically backwards. For the regular field calculations, points of interest can be identified on, again, the CT. And organs at risk can be identified from CT. So everything you get from the 2D planning, you can get from CT. Are all patients CT? Have you ever seen a patient going through your center that has not been CT'd?
No.
What about the electron patients?
Yeah, I was gonna say, when we had that girl come over from the hospital to get her keloid treated, she didn't get CT.
Okay. So how did they plan it then?
We just kind of clinically set it up, and the doctor came in, was like, yep, that's good, turn it on.
Yeah, that is, you just said it, that is what they call a clinical setup. So apart from the breast boosts that are usually CT because the breast is CT, the majority of electron treatments are done as a clinical setup, which means the patient's on the bed, the doctor comes in, looks at the area, draws on what area we want to do. We make a cutout and treat. It goes through the dosimetry because the calculation has to be done, but everything else is done clinically. What about things like spinal treatments? Maybe an emergency comes in, you guys haven't had anything to do with emergency treatments, have you? No. So this scenario, Friday afternoon, 3 o'clock, doctor phones down from one of the nursing units and says, I have a patient who's having a spinal cord compression, who has a spinal cord compression. We need him treated now. Does he or she, whichever the patient happens to be, need CT? This is an emergency on a Friday afternoon. Because it's a Friday afternoon, they probably would put her on CT. However, if the same thing happened on a Saturday morning, and they call in the therapist on call, they probably wouldn't be CT'd. Because there's no dosimetry available, right? Who comes in when we're doing CT planning? Who comes in when we're doing an emergency? This is a little off topic, but if we had an emergency patient come in on a Saturday morning and the doctor wants her or him treated, who would come in? Who would be called in?
The on-call.
The on-call therapist. And depending on how mobile the patient is, they may call 2 people in. There's usually one on-call and one backup. So they may call 2 people in if they have problems with mobility or something. Anybody else get called in? The physician would be there. That's it. You're it. If you get called in on a weekend, you have the physician. That's it. No dosimetry backup. Nothing. If you have to do a calculation, then you do a calculation and you do it by hand. Or there's a computer program that will let you do a hand calc. But no dosimetry, no dosimetry computers, nothing. You're left on your own. That's why during this semester, we'll go through calculations. You might not ever have to use them, but you need to know how. Okay, so let's go on to 3D treatment planning. So, data set, CT data set of the region to be treated is required with a suitable slice spacing. Typically, it's 0.5 to a centimeter for thorax, 0.5 for pelvis, 0.3 for the head and neck. So, anybody been on CT? Anybody seen CT done yet?
Megan and I asked, they told us, don't worry about it your first semester.
No, you don't need to do it on your first. Anybody who's been through CT, what are the slices? What thickness are the slices that are used? Anybody know? Did you ask those people who were through? No.
I just shadowed for 2 days.
Yeah,
And then
it's
went back.
usually anything from 0.3 to 0.5. If you're doing a head and neck or a brain, then they usually use 0.3 or 0.2. Remember, depending on the size of the area we're doing, we can have hundreds of slices. So you don't want to do too far. Okay, So an external contour representative of the skin or a mobilization mask must be drawn on every CT slice used for treatment planning. So normally we have, the masks are usually made and the CT usually can see the masks, so that is done. And then tumor and target volumes are usually drawn on CT slices. Organs at risk and other structures should be drawn in their entirety if those volume histograms are calculated. So you'll notice that once you get into planning or into dosimetry, they will do contouring. So the doctor usually contours the PTV, and then the dosimetrist will contour everything else. So if the kidneys need to be done, they'll contour the kidneys, or the lungs, or the spinal cord, or the rectum, or the bladder. All of that, depending on obviously where you're treating, that has to be contoured. Who was in planning? Who went through dosimetry? Somebody go, did they show you anything about that?
A little bit, it was after hours, so that he didn't have any patients pulled up, and he was trying to kind of give an abbreviated version, because he didn't want to be there until 7 o'clock at night. But,
Okay.
yeah, he showed us a little bit.
Okay. Okay. So this is basically what you're looking at. Okay. So here is the GTV, which is here. The PTV, which is here. And the CTV, which is here. So PTV, CTV, and PTV. So you have the bladder and the rectum. And I'm presuming because of this, where this is a prostate. So the prostate sits here, your bladder is contoured, your rectum is contoured. Some people would contour the head of the femora, 1, 2, because if they're treating the nodes along with the prostate itself, then the heads of the femur may come into the area. You can contour basically anything you want. Yeah, I mean, you can contour, I've seen people even contour the anus and contour the skin is always contoured, so you can do that. But anything you want to do, you can do. It just gets messy if you contour too much. Why isn't the spinal cord contoured there?
Where is the spinal cord in this image?
You're treating, what are you treating?
Prostate.
So is the spinal cord go down that far?
No. That's why I was asking him, like,
Then it's not available.
we could draw it in if you want to.
But why? The spinal cord does not exist down here. The spine does, but the spinal cord doesn't. If you went up slices, if you got superior slices, then you would see the cord end. So if the spinal cord doesn't exist, you don't need to contour it. So, treatment planning, okay, MRI or other studies, like PET, are required for image fusion. With many treatment planning systems, the user can choose to ignore inhomogeneities, often referred to as heterogeneities, to perform bulk corrections on outlined organs, or to use the CT data itself with an appropriate conversion to electron density for point-to-point corrections. So normally what we would do is to ignore inhomogeneities, depending on what we're treating. Because the majority of the areas that we're treating would be soft tissue, right? With some bones thrown in. But depending on if you're using a computer program that might be able to do inhomogeneity corrections for you, you might decide to do that. So CT images can be used to produce digitally reconstructed radiographs, i.e. DRRs. And there's your DRR. With superimposed beam's eye view. So your DRR would not have this in the middle. DRR would just have your MLCs. And that is where the DRR, so what are the DRRs used for again?
Reference of your
For?
portal images.
For?
Portal images.
Patient.
Portal images. So the DRR will give you, this is an AP image with the MLC in place. And that is your reference material or your reference image for your portal image. Your portal image is done with your treatment energy and your NV imager. Why don't we use a KV imager? Why don't we use a KV imager to do portal images?
Because it doesn't give you the beam view,
Say again?
it doesn't give you the beam view.
That's what I'm saying, but why not use a KV imager? You're right, because the KV imager does not have MLCs. You would not be able to see the MLCs for the KV imager. Your MV image is what is used for portal images. And here is a rather strange one. Okay, patient simulation was initially developed to ensure that the beam used for treatment were correctly chosen and properly aimed. Double exposure technique. Remember me going over what a double exposure was? Anybody? Okay, so the film is irradiated with the treatment field first, with any MLCs in the way, obviously. And then the collimators are opened to a wider setting and a second exposure is given. So here's your field size. And this is the open image to give the physician more anatomy so that they can look and see where they are. Okay, treatment simulation has more expanded role in the treatment of patients, consisting of determination of patient treatment position, which is done with CT these days. Identification of target volumes and OARs, CT. Determination of verification and treatment field geometry, which is the DRR. generation of simulation photographs for each treatment beam for comparison with treatment port films, again, DRRs, and acquisition of patient data for treatment planning, again, CT. So this is what they call a simulator port film. This came from what they used to call a conventional simulator. Conventional simulator was an X-ray machine, a converted X-ray machine with an image intensifier attached. So this is what it gave us. This is an X-ray film from the simulator. And these lines denoted the field size. So you have, and this would be what you might term in therapy a gradicule. Everybody seen a gradicule? So this would be a gradicule. Although this is wires inside the treatment machine, inside the simulation, the simulator. So these are your field size wires, and this would be a gradicule.
So this is from a machine that's completely separate from the Linac?
Yes. Yeah. This is just like a normal X-ray machine with some bells and whistles on it. Nobody has them anymore. But it's interesting to see them. So these, the same as the gradicule. So from here, the first one is 2 centimeters, and then these are centimeters. So this would be 2, 3, 4, 5, 6, 7. 2, 3, 4, 5, 6, 7. So this is a 15 long, or 15 wide, by 1, 2, 3, 4, 5, 6, and 6. So it's a 14 by 12. And some of the simulators also had little trays that you could put little blocks on. So you could actually check the blocks as well. So this would be used in place of a DRR, or a DRR's replacing this. And your port film is basically like your portal image. And if you had to put a gradicule in there, then you can see the actual difference, if there is any difference between them. They are efficient and practical to perform simulations of portal imaging on treatment units. There's always heavy demand for the use of treatment units for actual patient treatment. Use of them for simulation is therefore considered an inefficient use of resources. Tell that to everybody these days. These machines operate in the megavoltage range of X-ray of energies and therefore do not provide adequate quality radiographs for proper treatment simulation. They have poor image quality, as you can see from the last one. And as you probably have noticed, when you look at the portal images, are they good films? Are they good images? Are you getting used to looking at them now? Yeah, you can actually see what people are looking at if you use some imagination. So you have the DRR and you have the image, portal image. And you can see basically how things are going. It's a talent, you get used to them as you go on. So the reason for poor quality of the port films. Okay, you tell me, why are the port films so bad? Why can't we get decent films like this from our treatment machine?
Isn't there more scatter using the mega voltage source energy?
No, actually, there's less scatter. But
I thought the more scatter made the image hazy like that.
no. What the scatter in an MV image or the MV machine is forward scatter. So you have several, does photoelectric, Compton, hair production, does this ring a bell? Okay, so with diagnostic x-rays, means these, what type of absorption are we looking at with 100 kV photoelectric? Photoelectric is absorbed more in bones, therefore you get a better contrast. So with 6 MV photons, what kind of absorption is going on there? Think back. Say them again. Photoelectric, Compton, pair production, annihilation. Compton
Air production, right?
is actually, well, Compton as well. So, most photon energies with biological material in the megavoltage range are Compton interactions that produce scattered photons that reduce contrast and blur the image. The large size of the radiation source, either focal spot for linear accelerator or radioactive source isotope unit, increases the detrimental effects of beam penumbra. Patient motion during the relatively long exposures required and the limitations on radiographic technique also contribute to poorer image quality. So Compton does not absorb any more in bone than it does in soft tissue. So the contrast is worse. That's why you don't get a decent image. So here is a simulator. This is what I was talking about. So the fluoroscopic simulator. So you can see this is the machine, the bed, and there's a fluoroscopy unit at the front, the back here. Also, we did film, so you had a film holder there also. So we'd put the patient on the bed, we'd mark them, do x-rays, do a fluoro, make sure everything was good, then do some films. And there was a tray at the top here, we had little lead rubber cutouts, like little red rubber lungs and bony areas and stuff that we could put on that tray, and it shone a light, so we shone a shadow, so we could see where the blocks would be. They tried to make an up-to-date one, variant it, but it didn't, nobody was buying it, so they stopped making it. So that's what a simulator looks like. And then, of course, we have CT. which is what everybody uses nowadays. Based on CT or MRI, and referred to as CT simulators or MRI simulators. Everybody has a CT sim? Everybody's at least seen the CT sim? Yeah, okay. Patients may require an external immobilization device for the treatment depending on patient position or precision required for beam delivery. So, mobilization, obviously, to provide a reliable means of reproducing the patient position from treatment planning and simulation to treatment, and from one treatment to another. So that is, the immobilization devices have two fundamental roles. So immobilize the patient and provide a reliable means of reproducing the patient position. So, mobilization means including masking tape, Velcro band, elastic band, or even a sharp fixation system attached to the bone. This is for SRS. And this is an old mask that I hope never use again. That's old even for me. I don't remember doing that. So, simplest immobilization device used in radiotherapy is a headrest. This to me is not an immobilization device. This would be a patient positioning device. Because it's not really an immobilization device, is it? Really, if you think about it. Just because you put a patient's head on there doesn't mean it's going to stay still. So that to me is not an immobilization device. So anyway, shape to fit snugly under the patient's head and neck, allowing the patient to lie comfortably on the treatment couch. Headrest used for patient positioning and immobilization. They're all individually labeled. This one's B, C, F, and I think that one's D. I'm not sure, I have to look at it sideways. And we come to the masks. Patients to be treated with head and neck or brain are usually mobilization with a plastic mask, which can be heated and mold the patient's contour. Has anybody seen anything like this used? What is it?
It's like a special head rest
Call it
that's
a
mobile.
pillow.
Some sort of pillow.
Pardon? Mold care pillow. Okay. I've got some upstairs for maybe in the next couple of weeks. Look at them. The mask is affixed directly onto the patient couch and onto a plastic plate that lies underneath the patient, thereby preventing movement. You still have to rely on your patient because I don't know whether anybody's noticed this, but you still can move him with the mask on. Yeah, everybody's noticed that. So you have to rely on the patient at least helping themselves a little bit. Extracranial treatments such as thoracic or pelvic area, a variety of immobilization devices are available. Vacuum-based devices are popular because of their reusability. And it is a pillow filled with tiny styrofoam balls placed around the treatment area. A vacuum pump evacuates the pillow, leaving the patient's form as an imprint in the pillow, i.e. this. So another system, similar concept, uses a chemical reaction between two reagents to form a rigid mold of the patient. Has anybody ever seen those? They are these two regions.
Not reusable like that box.
That is correct.
It really seems like a waste of money.
There are some places that will use them without any problem, other places don't. The only reason I don't like them is the fact that they're using two chemicals and they get really hot when they're making the pillow, so it can be extremely uncomfortable for the patient. That's the only reason I don't like them. And the fact that they can't be reused. So here's another one. So they're making the plaster Paris type ones that they put on boards and individuals. Looks like the mummy's tomb or something. Can you imagine your patient wandering in and seeing these? So, I don't know. So, stereotactic. Required high precision of conventional mobilizations in radiosurgery. Stereotactic frame is attached to the patient's skull by means of screws and used for target mobilization, patient setup, and patient mobilization during the entire treatment procedure. So this is the actual frame that's attached to the patient. And once the patient gets on the either CT or the bed, they are attached to the bed by this frame, so they literally can't move. At least they can't move the head. And then this frame is actually used to check positioning with the machine, with CT and with the lanai. Simple hand calculations of the dose along with the central axis of the beam and the beam on time or Linac monitoring units. The source surface distance along the central ray is only as required. So patients with direct field or parallel opposed fields. So this is, we'll get to this later, much later on. This is to show you a method of how to calculate blocked fields. So, for example, oh, gee, should have sat so long. Okay, so you have a field. You have the central axis. So that's fine, that's an open field. And the doctor comes along and says, no, I think we'll do some blocks on there. So let's do some MLC. So we'll go there, and we'll go there, and we'll do something like that, and something like that. This is all shielding. So now the dosimetrists have to figure out how to do a calculation with those blocks in place. It's called an irregular field. If we use an open field, then we'd use the equivalent square. Everybody remember what the equivalent square is? So if I said to you, I have a 10 by 20 field, what's the equivalent square? 10 by 20 centimeter field. What's the equivalent square? How do you do that? How do you calculate that? We went over this a lot last semester while we were upstairs. So you have, okay, so we'll say that this is a 10, excuse me, wrong. This is a 10 by 20 field. How do you do the equivalent square?
Would you add them together and divide by 2? Like would it be 15 by 15?
No.
No. We can't.
I would find the area and then take the square root of it.
There's an easier way.
Is there an easier way than that?
So you have an x times y whole square, or times 2 actually. You have x times y times 2 divided by x plus y. So we have 10 by 20 times 2. So what's 10 by 20?
200.
Huh?
200?
Times 2.
400?
400
divided by 30?
divided by 10 plus 20, which is 30. So we'll take that one off. 3 into 40.
13 point something.
Pardon?
13 point something.
Yeah. So, you have to find the equivalent square, and then with the blocked fields, you have to find the equivalent square of the blocking, and then we use this Clarkson method sometimes to find the blocked field size. So there are two ways, or there are several ways of doing the equivalent square. You use whatever way you find easier. If it's easier to do the area and use a square root, then do it.
But it comes up with a little bit of a different answer because it's like 14.1 for that. Is that enough to make it a difference?
It
Like,
can be, yeah, it can be.
so is it better to use the other one?
Normally what you would do is if you have tables, and you'll notice there are tables in your purple book. Look at the table, see if there's a table, and there is. In most of the departments, you will find a book of tables. There may be some of them on the machine. There definitely are some in the physics department, in Dosimetry. And you can look up the equivalent square. So all you do is look up a 10 by 20 and it'll give you something like 13.8, I think is what it is. But you can do, it's not gonna make an awful lot of difference. But depending on what answer they're looking for, it depends on what way to count.
I guess it makes sense because that's always gonna be a little smaller than the square root. Because
Yeah.
the square root is the exact, and it's gonna give you just a little bit smaller one.
Yeah. So, 2D planning. The patient's shape is represented by a single transverse skin contour through the central axis. Makes sense, right? You're doing a 2D, so you have one contour through the middle. Contour may be acquired using lead wire or plastic or plaster or CT. Patient data requirements, you would use CT, this is 3D. And everything would be there from the CT. So CT planning, external shape of the patient must be outlined for all areas, which we saw on the CT. And targets or internal structures must be outlined, which again we saw the PTV and the CTV and the GTV and the bladder and the rectum. If you're treating the chest, you have the lungs outlined on each slice. This is why if you're doing, say, 3mm slices, and you end up with 250 slices, you're sending these across to the dosimetrist, and they have to contour whatever they need to contour on each individual slice that they're interested in. So you may have done a CT this long, and they may be doing a plan with this much, and they have to contour every single slice. So they have maybe 100 slices to go in and contour the lungs, the PTV, the GTV, the CTV, and the cord, and the mediastinum, and the carina, and anything else that the doctor wants contoured. So you have to be cognizant of that. So, targets and internal structures, and then densities for each volume. And see whether they want heterogeneities to be applied. And again, we go back to the simulator. Diagnostic quality, X-ray tube, rather than high energy. Okay. So again, modern simulators provide the ability to mimic most treatment geometries attainable on megavoltage treatment units and visualize the resulting treatment fields on radiographs or under fluoroscopic examination of the patient. So the simulator was the simulator for the treatment machine. So it could mimic almost everything that the LINAC could do. But the CT can't. The CT can't mimic how the patient is. The CT will mimic how the patient is positioned, but they cannot mimic the movement of the treatment machine. Does that make sense? Whereas the old simulators could mimic basically any movement that the LINAC could do. with a few exceptions, because you had the image intensifier and film holder down here. But as far as rotating goes, you could actually do any particular field that you wanted to do. So again, here are the field sizes, the adjustable field sizes. So in this case, you would see, if you wanted to see a 10 by 20, then you set these jaws or these wires to a 10 by 20. So you can actually see them and you could film them. And that gave you a fill in order for you to see once you get onto the treatment machine. And the gradicule as well. So that was included in the machine. So again, you see the kilovoltage range, preferably attenuated with a high Z material, such as bone. So they had a good, diagnostic radiograph. The majority of sites, the disease was not visible in the simulated radiographs. Therefore, the block positions can determine only with respect to the anatomical landmarks. So, beam geography. Here's a lateral head and neck. So, what are we doing here? So, this is a head and neck patient, lateral. This is shielding. The pink is shielding. And when we were using the simulation, the conventional simulators, we would get the physician to draw actually on the films the shielding that he wanted. And then we would make blocks, actual cerebellum blocks, to these marks. So what is this shielding? Anybody interested? What is this shielding?
Spinal cord.
Spinal cord. Now, when would we use this? When would we put that shielding on?
Right before treatment.
We're shielding the spinal cord. When do we need to shield the spinal cord? What's the tolerance of the spinal cord?
You mean what dose we get to?
Yeah.
45?
45, maximum. So, this would be added. So when we start treating the patient at first, this would be open because there's nodes that run along the spine. So we need to treat those. So we would shield this. This is just soft tissue, normal tissue. We don't need to shield that, but most of them do. And we would have this open. And this is what they call the off cord. So at 4,500, we would place the shielding in to protect the cord and only treat this area. But there's still nodes over here that have to be treated. So what can we do about that? We're shielding them from the photons at 4,500.
So you treat with electrons?
we treat with electrons. So, when we're treating the photons, we would put this shielding in, and then we would do dual treatments. So we would treat with the photons first, and then on the same day, we would put an electron field on over exactly the same area. So we could treat the nodes without treating the spinal cord. So this would be added at 4,500 as a maximum. And if you look carefully up there, it says field phase 3.
So what does that mean, like the third phase of treatments?
So what we'd probably do is we'd have an open field, and then we'd have a smaller area, and then a much smaller area with the cord being blocked and electrons added.
So would there be blocking all in phase 1?
Yes. Yeah, you'd probably have one here, and maybe some over here as well, depending on what the dog wanted. And perhaps a little piece over here just to shield the base of the straw. It really does depend, it's an individual doctor type thing. So after proper determination of beam geometry, patient contours may be taken at a plane of interest and be used for treatment planning. Although more sophisticated devices exist, the simple and most widely available method of obtaining a patient contour is through the use of lead wire. Much easier to do a CT contour, mustn't it? I did like using the wire. The only problem that we used to have with moving the wire is actually changing the shape of it from getting it off the patient onto the paper and doing contour with a pencil. Because it really took 3 hands. Okay. CT. Anatomical information on CT scans is presented in the form of transverse slices, which contain anatomical images of very high resolution and contrast. CT images provide excellent soft tissue contrast, allowing for greatly improved tumor localization and definition in comparison with conventional simulators. So patient contours can easily be obtained. So you have the patient's skin contour here, the target, which is here, and organs of interest, which in this case is the spinal cord. So what would you say this is supposed to be? Obviously, we're looking at the cord. What's this? Anybody give me an idea of what this might be? What's this then? Patient's head, patient neck?
Pelvis.
Huh?
Pelvis?
No,
That's not bladder or
no,
rectum?
no. Too small. This is a head and neck.
Two-way target.
Pardon?
The red thing?
Yeah, larynx or nasopharynx or something like that. This would not be in the pelvis, this size of the lumen. Yeah. Well, no, I'm just saying that the spinal column is not shaped like it is in the pelvis. So this is a head and neck.
The cord goes through the foramen, I think is what it is.
Yeah. So this is the shoulder. So what's wrong with this then? If I say that this is a head and neck, that's the shoulder, what's wrong with it? Nobody sees anything wrong with that? Where's the other shoulder? Down. So what's probably happened is that we're treating the shoulder and either they haven't got the shoulders down far enough, or one's up, one's down.
Would that be intentional because they're trying to avoid something on the other side? Could they retract? that
Normally
shoulder?
not. Normally if you retract one shoulder, you retract the other, because that would mean your patient's off kilter and off, they're not straight. So yeah, somebody hasn't got their shoulders correctly placed. So position of each slice and therefore target can be related to bony anatomy through the use of a scout or pilot images obtained at this type of scanning. So this is a pilot or a scout. So this is an AP scout, this is a lateral scout. So this basically tells you, first thing first, if the patient is straight. And if the patient is not straight, then you're gonna have to do something about it. This is before the CT actually starts. So you have this. So is he straight? This is AP scout. Does he look straight?
No.
Why isn't he straight?
His head looks shifted.
Say again?
His head looks shifted.
Head looks tilted.
Yeah.
Which way?
To his left. To his left.
To his left. So he's tilted this way.
Yeah.
Okay. So he's not tilted this way. So you're saying he's tilted this way, not this way.
Sure.
He's relatively straight, actually. What about the lateral scout? Difficult to tell with a lateral scout, actually. He looks pretty good there.
Don't forget your clock's behind.
Pardon?
Don't forget your clock is behind.
I know I've got my watch
Okay.
here.
I'm just making sure.
Yeah, so we'll leave it there.
Yeah, I have to go.
Um,
I have an appointment at 1, so I have to go.
Yeah, okay.